And do you swear or affirm that the testimony you're about to give is true?
I do.
Okay, identify yourself for the record and fire away.
My name is Dr. Giovanna Mahar. I am a doctorate of nurse anesthesia practice, and I come today as a representative and president of the New York State Association of Nurse Anesthetists, or NYSANA. I would like to thank the assembly members for inviting me to come today and represent my organization. I've submitted my written testimony, and I hope to keep this short and sweet for you. But if you do not know, NYSANA is the organization that represents over 1,600 CRNAs and resident registered nurse anesthetists. We are nurses who are allowed to administer anesthesia. We have been doing so for greater than 150 years. I've been a nurse for 20 years. I've been a CRNA for 12 of those years. When I first graduated from my institution at Albany Medical Center, I went to Massachusetts, and we can talk about that a little bit later. But in 2013, I came back home to Albany and started working in the OR there, as well as an educator in the Center for Nurse Anesthesiology. I currently hold the Assistant Program Director position at that facility. In New York, CRNA practice is not codified in law. Instead, the scope of practice for CRNAs is defined through the health department regulations and education requirements. What this does is imposes unnecessary restrictions to practice and requires that a CRNA must practice under direct physician supervision. On March 23, 2020, Executive Order 202.1 was issued and allowed CRNAs to administer anesthesia without physician supervision. The supervision waiver was once again reinstated by Governor Hochul in Executive Order 4 in response to the state of emergency created by the healthcare worker shortage in New York. The waiver of the supervision requirement was significant for CRNAs because what it did was it provided us the opportunity to show the public what we were made of, okay? The things that our education has provided us. We provided to New York hospitals and healthcare facilities maximum flexibility in the utilization of the CRNA during a period of tremendous uncertainty and stress. These orders showed that CRNAs could practice without supervision with no negative patient outcomes. CRNAs led the way in a variety of settings. In fact, we put together, NYSANA, a task force to track the experiences of our members. Oftentimes, CRNAs were on the front lines. We organized COVID-19 airway teams. We converted operating rooms into ICUs. We consulted on prone positioning, assisted pulmonologists with mechanical ventilation parameters and management, oversaw sedation and prescribing, placed invasive lines, and performed intubations. CRNAs also managed patients in COVID intensive care units. And those things included ordering and prescribing, supervising, placing invasive lines such as central lines and arterial lines, and also worked as part of our rapid response and airway management teams. None of these behaviors or practices that we used at that time were new to us as a profession. We strongly believe that there needs to be enacted statutory changes to continue with the executive orders allowed during the declared emergency. The takeaway lesson for CRNAs is that it is well past our time in New York State to recognize us for our full scope of practice. We believe that Assemblyman Gottfried's bill, A7268, will do just that, and we are really working to get it through in 22. So I would like to just take a moment and thank you, Assemblyman Gottfried, for your leadership in being a champion for CRNAs. During the pandemic, we can't ignore that the importance of this legislation, even though there was a global health pandemic, helped CRNAs. We provided critical patient access, healthcare delivery, and managing healthcare costs even was not a pandemic. If we were good enough during a pandemic to provide care, we should be good enough to provide care when everything is going as it should. In fact, CRNAs practice under the very same standards our anesthesiologist colleagues do. We provide anesthesia in collaboration with surgeons, dentists, podiatrists, and other qualified healthcare professionals. Nurse anesthesia services are critical to rural healthcare services. Oftentimes, we are the primary providers of anesthesia in rural America per our national association, the American Association of Nurse Anesthetists. CRNAs are needed 24/7 to address emergent situations in our institutions. Oftentimes, we are the ones that are on call when there's an emergency C-section that's needed, or even a trauma coming through our emergency room. More than 30 years of scientific study has demonstrated that CRNAs administer safe, quality care with patient outcomes equivalent to those of our anesthesia colleagues. CRNA practice in every setting where anesthesia is offered for every type of procedure, including complex procedures, like the open heart surgery procedures to the colonoscopy. In every category of patient, from our micro preemies, our very little babies, to our geriatric patients. The demand for anesthesia care and services will outpace the supply of providers. New York State is the only state that does not have a scope of practice bill which enables CRNAs to practice to the full extent of their education and training. I'm going to say that again a little bit differently. We're the last. The limitation will impact patient access and care because the demand will outpace the supply. CRNAs play a critical role in addressing increased healthcare costs by providing safe, quality care at a cost that ensures access to anesthesia for millions of Americans. More fully utilizing these advanced practitioners facilitates experiences with greater efficiency in the delivery of care. Our hospital administrators, healthcare facilities, and of all types, policymakers and healthcare providers must find ways to improve patient access to safe, quality care without further burdening the healthcare system. CRNAs align with the needs of today's healthcare system because they deliver the same safe, high-quality anesthesia care as other anesthesia professionals and help control the rising cost of care. NYSANA is committed to the belief that CRNAs play a critical role in the delivery of healthcare services, and the lesson that we must learn from the COVID-19 pandemic is that it is beyond time for New York to join the other 49 states in passing a scope of practice bill for CRNAs. Thank you.
Thank you. Couple of questions. Under the executive order, which I gather has been reinstated at least for the next couple of weeks, under the executive order, how does the relationship between the CRNA and some physician compare with the relationship that would exist under the CRNA bill? In other words, collaboration. What verbs are operative under the executive order, and how does that compare with what would be the rule under the bill?
So our bill is a collaboration bill. It asks for our full scope of practice, but it also asks for us practicing with a physician in collaboration with a physician. So there are states out there now that are opt-out states. So those CRNAs do not need to practice at all under the supervision of a physician. We're not asking for that. There has been a lot in our extensive history about our groups working together and finding a compromise. This is our compromise. The executive orders allowed full scope with no supervision. So this is where we have taken that step forward and feel like this is a great meeting in the middle.
Does the executive order, and I apologize for not being directly familiar with the actual language of it, does the executive order require a collaborative relationship with an MD?
No, sir.
So the executive order, just to use common terminology, is arguably a couple of notches to the left of where the bill is.
Yes, sir. We would love full scope without physician supervision.
Interesting.
That would be our end goal, yes. But as I've said, we are the last of the great 50 states to recognize CRNAs. So this was our try to just finally get seen as a profession in this state.
And I'll put to you the same question that I put to the anesthesiologists. Are you familiar with any medical literature, or I guess I would also ask, do you know if there are any papers being prepared for publication in the medical literature reviewing the experience under the executive order?
I cannot say that I have heard of anything. I do work in a medical college, so we do a lot of research there. I have not heard anything, but I believe that if CRNAs were as unsafe as the rhetoric that we've heard, then I believe we would have great evidence of that, and it's just not there.
Okay.
So in short, no, I don't know of any poor outcomes because a CRNA provided care without supervision.
Yeah. I mean, I suppose the medical records of all of the instances in which a CRNA was involved, those records are not going to disappear. Somebody could decide tomorrow to go do research on those records. It would be a shame to miss that opportunity, I would think.
I believe.
Easy for me to say because I'm not about to go out and do it. But
well, I appreciate that.
Want me to do it either, I assure you.
I appreciate that, and I will definitely put that on my agenda to do.
Okay. Any other questions?
Yeah.
Yep.
So for the benefit of the hearing, as we're going over what might be differences in education or training, could you just explain whether these are registered nurses who have taken additional training?
Yes, ma'am.
Could you explain what that is?
Yes, ma'am. So I will just use me as an example. I went to the University at Buffalo. I got my bachelor's degree there. After graduating, I came back home. I spent 6 years in a surgical ICU. So I have extensive ICU training in a level 1 trauma center, and I love to tell people, I love to brag a little bit. Albany Med has the largest catch basin in New York State, so we kind of see everything. And then after that, I applied to a master's program. I had to do 26 months of anesthesia training, in which there are national standards that are set. I had to have a certain number of cases. I had to do a certain number of open heart procedures, central line placements, arterial line placements. I had to meet certain standards in order to be able to sit for my national boards. I took my national boards, and then, as I told you, I'm an educator, so I went back and I got my doctorate at Virginia Commonwealth, and I spent 2 years receiving my doctorate, so working hard to get that done. What I would like to say, though, is in the early 2000s, there was an IOM report that came out that said nurses should work to the full scope of their practice. So over 20 years ago. And at that point, the CRNAs said, we're going to step up. We want all of our nurses, all of our CRNAs to be doctorally prepared. So by 2025, all of our programs will only graduate doctorally prepared CRNAs. So I went kind of the roundabout way in getting it, but actually starting this year, my program will only graduate doctoral CRNAs. Does that answer your question?
Mm-hmm. Thank you.
Thank you.
Okay. Other questions? No? Okay. Thank you very much.
Thank you for the opportunity.
Thank you. Deborah?